Welcome back to Two Nobodies, everyone. Rupesh is here again with another great guest. You know, health is an area that our podcast has focused on in a number of ways. We had Dr. Emma Allen Verco last year talk about the gut. We've talked about hormonal health. We've talked about the low back. We've talked about musculoskeletal injuries. We've talked about health and fitness overall as well. This is an area that I have always been interested in, but never really dove deep. And so I think we have the right guest for us today. Dr. Joel Lexchin has joined us, and maybe I'll give a bit of a bio on Joel, if that's okay for everyone. Joel received his MD from the University of Toronto in 1977. He's a Professor Emeritus in the School of Health Policy and Management at York University in Toronto, where he taught health policy until 2016. And he's worked in the emergency department at the University Health Network, also in Toronto, for 33 years. So someone who definitely knows what he's talking about. And he's published 2 books. In 2016, Private Profits versus Public Policy, the Pharmaceutical Industry in the Canadian State. And this is the book that I saw in stores, which caught my attention. Doctors in Denial, Why Big Pharma and the Canadian Medical Profession Are Too Close for Comfort. Dr. Joel Lexchin, thanks for joining Two Nobodies today. I told you you're kind of an honorary nobody today, so hopefully that works for you. But appreciate having you on our show today.
Well, thanks very much for the invitation, and I'm glad to be here and to be an honorary nobody.
Thanks so much. So I always like to understand our guests and where they're coming from. I do want to for sure understand why you chose to focus on, drugs in the pharmaceutical industry and that side of health policy. But what drove you to become an MD to begin with, like your interest in medicine?
Okay. So as your listeners, viewers can probably tell, I'm not young. I was born in 48. So I'm a product of the late 60s, early 70s, in terms of my university experience, my political experience. And I saw medicine as a way of furthering social activism. I think that it's important that everybody is treated equally when it comes to health care. I didn't see that when I was in the 60s, 70s. Even now, I don't really see it. But so I view medicine as an extension of political activism in terms of making sure that everybody gets the health care that they need and that it's affordable, and that we try and eliminate racial, sexual violence or biases. And all those things combined to make me go into medical school and then to continue with the political part of medicine after I graduated.
What do you mean by the political part of medicine?
Well, I mean, you can view medicine as being just go into the office, or in my case, go into the emergency department, see the patients who present, and then go home and watch TV or go play golf or whatever. Or you can see medicine as being not just seeing patients, but also advocating for policies that further social justice goals as they relate to healthcare. So that's what I meant by by politics, is the social justice part of medicine.
And so is that something that do you notice more and more MDs are getting involved in that space, or do you think that there's a bit of a gap there right now?
Well, I know that amongst the group in our emergency department, we're about 90 people. We serve
Mm,
two hospitals, and there's certainly a significant number of people who are involved with social justice issues. So during the worst of the pandemic, there were some people who were advocating for the homeless in terms of making sure that they had places, if they were had COVID, that they had safe
mm,
places to go. Toronto winters aren't as bad as Edmonton winters, but they're still not
mm,
very pleasant if you're
right.
homeless. So we had people advocating for that. We've got people who are advocating for treatment of addiction disorders.
Mm,
Um, so I think that there's a substantial number of people, at least the ones that I know, who are pushing on a variety of different social justice issues.
yeah. Okay. And then this focus on pharmaceutical policy. When I saw your book in stores, and when it what caught my eye was just, you think about Big Pharma, and I don't know, as a Canadian, if you're watching American TV, you're seeing all the advertisements on there. You're watching CNN. Every single ad is a Big Pharma ad, and so the connection, I think at least for me anyways, I think that there is this inherent embedment of Big Pharma in the American medical system. It doesn't seem as overt in Canada, but not to say that it doesn't exist. So when I saw this topic, I definitely wanted to understand Big Pharma's influence in our healthcare system. But so for you, getting into linking to that, what was the drive to then get into health policy and then focus on the pharmaceutical sector in particular?
So I think that medicine, healthcare in general, and this is oversimplifying it, but you can look at things from the point of view of an equity, equality lens, um,
Mm,
or you can look at it from the point of view of a transaction. So you're the patient, you come and see me, I give you a service, and you pay me either directly or your insurance, or in Canada's case, the government pays me. And this is really a transaction, and that in that sense, it's not much different than you going in to a store and buying a new computer, buying
mm,
something else. It's a transaction. You're get you want something. In my case, it's healthcare. Um, it could be a commodity, and you pay for it. And I think that's the wrong way of looking at medicine and looking at healthcare. But from the point of view, and this is most clear when it comes to pharmaceuticals, because in most of the services that you get, most of what you get from doctors are services, not commodities.
mm,
Um, you get, you come, I diagnose you, I examine you. These are not commodities, they're not objects. Um, but when we come to pharmaceuticals, it is. You're there's a hard product out there, and that I think lends itself even more to commodification. And I think that's one of the reasons why we see the ads on American TV. I think in
mm-hmm.
that country, medicines are treated even more as a commodity than they are in Canada. So you can, just the same ways you can advertise new cars, new computers, new whatever, you can in the States advertise new drugs. Um, and that is a view of medicine that I think takes out the service to the public and replaces it with just a cash transaction.
Is there a difference in the consumer experience? Do you know in the United States and here in Canada? So if someone saw in the United States, if someone saw a drug on TV, could they go to their physician and say, "Hey, I really want that drug"? and does that experience differ here in Canada?
So yes, in the States you can, and there have been studies that show that if patients go in see a doctor and they ask for a drug that they've seen on advertised on TV, then in a reasonably large number of cases, doctors
Mm.
will prescribe that drug even if they don't think that it's not necessarily the best one for their patients. And they're concerned about um, making sure that the patients are happy, making sure that patients don't abandon them and go to another doctor. Um, in Canada, and there was some research done on this about I think 2010 by
Mm.
a friend and colleague of mine who was working at UBC at the time, and she found that doctors in Canada would also would also prescribe something that people had seen on TV, but the difference is that people in Canada are much less likely to see those ads
Mm.
than they are in the United States. But doctors in
Okay, so
Canada have the same concerns. If I don't prescribe it, then they'll just go down the street to somebody else who will. Um, so um, there is some, doctors are human and they want to please people the same way that everybody else does, and they will give in or they will listen to what patients want and sometimes do what the patients are asking, even if we don't think that it's necessarily the right decision.
and that's sort of my next question is, and I don't know if there are differences in each province, but um, doctors can freely then prescribe, or like if they think they want to try out a certain drug or so, or do they have, are there certain I guess standards or things that they have to comply with before they can, if a patient asks for something that they've never prescribed with, can the doctor use their own discretion to do that, or are there rules around that?
Essentially, there are no rules. I mean,
Okay.
within reason. So you can't come in if you come in to see me with a common cold,
Yeah.
then I won't I won't prescribe you a drug to treat cancer. And if I
Mm.
do, um, the Provincial College of Physicians, the licensing body, is likely to hit me over the head and tell
Mm.
me not to do it again. Um,
Mm.
but within reason, doctors can prescribe whatever they want um, when a patient comes in, and this is done sometimes for good reason. So some groups of people so let's take pediatric cancer. There are very few
Mm.
studies that have actually looked at um, treatment of cancer in children specifically.
Mm.
Um, and that's because there are a lot of children who get cancer. So we take what's been done in adults and we then try and adjust that treatment for children. So we're prescribing what's called off-label. In other words, the federal government, Health Canada, has never approved drug X for the treatment of a childhood cancer, but they have
Mm.
approved it for children. So we're trying to make sure that we're taking into account the difference in age, body size, etc. But we're still prescribing a drug that has never been actually tested. But that's the best we can do in those cases. Um, in other times, though, doctors prescribe off-label, in other words, for things that weren't approved by Health Canada. And when we do that, by and large, if there's no good evidence to back it up, um, people are not helped, and there's more likely to be side effects from that kind of prescribing.
Okay. Okay. Um, you talked about the commodification is kind of high in the United States. Is that increasing in Canada, would you say, in terms of how doctors, I guess, uh, is there like an overprescribing? Is that commodification happening in Canada? What is that looking like?
So there's both underprescribing and overprescribing.
Okay.
Um, so underprescribing um, is occurring in with high blood pressure, for instance.
Hmm.
Not everybody who's got blood pressure high enough that requires treatment is getting it. There
Really?
are people out there who um, have the HIV virus who are not getting um, triple therapy to suppress their
Hmm.
viral loads. Um, but on the other hand, there's definitely a lot of overprescribing. Um, and this is due to a variety of things, but one of them is what's known as disease mongering. And this is
Okay.
drug companies, um, well, drug companies produce useful products. I mean, I'm old enough, I take a few of them. Um, But on the other hand, drug companies are businesses and they want to expand their market. And so drug companies are trying to expand the boundaries of disease so that they can sell more of their drugs. One prime example of this was after 9/11 in the United States, where
Okay.
there were one company that was selling um, drugs for anxiety, had pictures of people looking really worried with headlines, in these times of fear, playing on this idea that, that something can drop out of the sky, another plane,
Mm.
what have you, and that people were getting frightened about this, and if they were getting frightened about these things, the the solution was to prescribe this company's anti-anxiety drug. And we see disease mongering in other ways too. So in Canada, for instance, there were ads directed at doctors for what's called low T, in other words, low testosterone, um,
Okay. Yeah.
with the implication from that if you give this to men, 70-year-old men will be in swimming pools playing water volleyball and frolicking around. Um,
Mm.
Clearly not anything that was justified by any evidence at all. So drug companies are trying to expand their markets, and that's one of the contributors to overprescribing. Um, there's also the idea that drug therapy is the first choice when it comes to any health problem. Um, so for mild depression, the recommendations, if you look at guidelines, are non-pharmacological treatments.
Mm.
So exercise,
Right.
um, a variety of things that don't involve popping a pill. Um,
Mm.
but if you look at the ads that you see in medical journals, um, you you get the idea that these kinds of non-drug treatments don't work, and you better prescribe. So that all these things, and it's not just the drug companies. There are other factors also that push overprescribing, but overprescribing is a definite problem, and there's now a movement of which Canadian doctors are in the lead called deprescribing. In other words, helping people stop taking drugs that are doing them more harm than good.
Right. Okay. Has COVID in any way enabled any more overprescribing, or has that sort of, Yeah, as that you talk about the disease mongering piece, right? I mean, I wonder if this is COVID presented a right opportunity for big pharma to kind of further do some of that.
I don't think that, well, there were some drugs that were being promoted as um, for COVID that probably turned out to be not terribly effective. So I'm thinking
Mm,
of something called remdesivir, and I don't know if you followed it, but back when it was
mm-hmm,
introduced, um, I think in the summer of or early summer of 2020, um,
mm,
Anthony Fauci from the US was touting this as a game changer
mm,
in terms of treating people with COVID. And that was the message, certainly from the drug companies, but that, or the company that was making it, but it turned out to be really a minor benefit, not stopping people from dying, not stopping people
mm-hmm,
from ending up in the ICU. But
mm,
by and large, no, the drug companies, I don't think were pushing products um, during COVID. But on the other hand, there was certainly, and especially in the early stages when we didn't know a lot about COVID, there was this panic to try almost anything in the hopes that it would do
mm,
something about COVID. And we still see those messages, not from the drug companies, but from people like your new premier, at least at one
mm,
point, touting, I believe, ivermectin, which is a
mm.
great drug if you've got scabies or some
Or for
other
veterinary
um,
purposes or something like that.
yeah, but
Yeah, yeah,
not for COVID. But
right.
so there was that push to 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 look for things that might help, and that might have fueled some increase in prescribing.
Yeah. Before I we dive into the last book you did, do you think that the reputation of some of these big pharmaceutical companies, and I don't know what it was like before, but I imagine that there was you know, there were a lot of suspicions by people. The reputations may have not been so good. At least my view on them hasn't been so good. But do you think that's changed because of some of their, it's like, the responses that they've had towards COVID in terms of how quickly they've been able to develop vaccines and all these sort of things? Like, has the reputation improved for some of these big pharmaceutical companies?
Yeah, I think that they've certainly gotten a bump, um, especially because of the vaccines. I think that
Mm,
people's view of them has improved. Um, But you also have to remember that these vaccines were, well, they were made by the drug companies. Most of the money that went into their
right.
development, and here we're talking about tens of billions of dollars. I think
Mm,
the last figure I saw was about public spending on either the R&D for the vaccines
mm-hmm,
or purchasing of them was about $80 billion, US billion, so
right.
100 billion Canadian. Um, and but the public isn't getting the credit for
Mm,
spending that kind of money. Most of the credit is going to the drug companies, and they
mm,
certainly played a role in this. But they're also doing very well. Pfizer was expected to generate or generated, I think, 21 or $22 billion in 2021 from the sale of its vaccine. Moderna generated 17
mm.
or 18 billion in revenue. So the drug companies have also done quite well financially from the vaccines that they're making.
Yeah, and if I were to if I were to connect a couple of things, the $80 billion or however much money has gone into supporting these drug companies for these vaccines, it would have definitely de-risked, the investment that those companies are making. Hey.
Sure, it definitely did. I mean, you had companies, you had governments putting in orders like Canada did, the U.S. did, most of
Mm,
the West did, to these companies, um, for vaccines that were still in the development stage. We didn't know
mm-hmm.
if they were going to work or not, but we were giving the companies billions of dollars, in advance purchases because we wanted to be first in line to be able to get these things.
I have to ask then, because this is spurring another thought, is that if it takes that kind of level of public investment to make the business case attractive for these companies to invest in these vaccines, what about for cancer drugs? Like are these companies actually, do they have the incentive to actually look into drugs that actually will cure cancer, or is that not there? Like what, like it makes me question that part of it.
Well, I think the idea that drug companies are actively suppressing certain kinds of drugs is a myth. There is
Okay.
no secret vault in the basement of companies where they've got the cure for cancer, and they're just
Mm,
not um, they're not selling it because that would, once people are cured, that would destroy their market.
mm,
Um, and cancer drugs, the ones that are coming on the market now, are very profitable for drug companies. We're seeing in Canada, we're seeing these drugs going at, oh, 30 to $50,000 per person per year. Um,
mm.
and in the United States, you can take that figure and probably triple it. Um, so what drug
Well, what gives
companies
you,
are
Joel?
not,
What
sorry,
gives you that assurance? No, that's okay. What gives you that assurance? And I'm not saying that I'm like, I'm not trying to get into anything crazy here, but like, what gives you that assurance that, um, because I imagine this is mostly economics, right? Like this is all about, for the most part, profits. And so, the whole notion that they don't necessarily know how to solve or treat these diseases. Like, what gives you that assurance that they don't have that, and that they're that maybe there's a bigger market out there to. I'm not saying there's active suppression, but like I guess, yeah, just wanted your insights on that a little bit more.
so, well, first of all, I think that this idea about the cure for cancer is somewhere in a drug company vault is the same as the idea that the automobile companies had cars that would get 100 miles per gallon of
Mm,
gas, and they just weren't selling them.
mm,
These are conspiracy theories. But on the other hand, I mean, there is a grain of truth in that drug companies, because they are primarily motivated by profits, they do focus their research and development in areas where they think that they're going to make the most money. So there are
right.
some areas that are neglected. This especially um, when we look at what are called neglected tropical diseases. So there are problems out there that that are killing hundreds of thousands of, not millions of people annually in low income countries,
Mm,
that are not, that there's not a lot of research going on for new treatments because the people in those countries can't afford them. Um,
mm,
so the drug companies don't see a profit in that. So in that sense, I mean, the drug companies are doing things or not doing things based on profit, but they don't have, as I said, secret.
Yeah.
Um,
Yeah. Well, I appreciate you entertaining that. I thought it's just something that I need to ask you. So let's go into the last book that you wrote, the driver behind that book. Why was it important for you to really develop that material?
well, I think my experience as a physician, and also my experience in in the role of doctors as drivers of social justice led me to believe strongly that the value of um, the medicines that we have was not being
Mm-hmm.
realized. And it
Mm.
was not being realized because, one, drugs were overpriced, um, and two, because of the relationship between the drug companies and physicians, and not just physicians, but also government, meant that drugs were being approved that didn't have good evidence, that drugs were being left on the market that were potentially unsafe for a lot of people, and that doctors and the medical profession in general was in some cases siding with the drug companies and not siding with our patients.
Mm. Okay. Um, yeah, that's really interesting. Um, So when you talk about the relationships that are being formed, what is that like? When does that start happening with physicians? Like, does it start happening as soon as you know people leave the people are as soon as they graduate from medical school, or what is that? When does that relationship start, and how does that get formed over time?
Well, like all relationships, it's this is a complex area, and it actually starts in some cases during medical school. Um,
Okay.
so at some points, you you medical students are getting things for free that come
Mm.
from drug companies. So back in the 2000s, um, at the University of Toronto, every year there was what was called colloquially called Pain Week. Um,
Okay.
so Pain Week was they got all of the different health science students, so not just
Yeah.
medical students, pharmacy students, nursing students, physio students, etc., and they had a week devoted to diagnosing and treating pain.
Mm-hmm.
Um, But as at that point, as part of that week, you had a at the University of Toronto, you had a speaker who was on who was an MD but was on the speakers bureau for Purdue Pharma. Purdue
Mm-hmm.
is the maker of OxyContin, so he was
Mm.
giving lectures to the students, and you had textbooks being given out for free, at least to the medical students. I don't know about the other students, but
Mm.
the textbook was sponsored by and had been developed partly by Purdue.
Wow.
So you were getting these interactions between the industry and medical students, at least indirectly. Um, you have people at, I don't know if things have changed, but you were having people give lectures without um, acknowledging their possible conflicts of interest. So
Mm.
people who were on advisory boards of drug companies. Um, so the influence can start in medical school, and then once you're finished in medical school and you're in the hospital, you're potentially seeing um, representatives from drug companies. These are men and women who um, go into hospitals to try and talk to doctors about what to prescribe.
Mm.
Your Some cases, drug companies are sponsoring um, what are called rounds, where you're talking about medical disease topics, or you're talking about um, patients who have presented with what cases that are so-called interesting. Um, you're getting lunches that might have been paid for by drug companies. You're working with
And
people.
this is happening. This is happening in Canada, Joel.
Um, it's happening. I don't know how widespread it is these days. It was certainly
Okay.
reasonably widespread 20 years ago.
Okay.
It definitely is continuing to happen in doctors' offices
Mm.
um, across Canada. The estimates that I've seen are that about 70% of doctors will see sales
Wow.
representatives, the men and women who come to their offices to talk to them about the products that their companies make. Um, and then you have other kinds of interactions. So you go to any reasonable size medical conference, and drug companies will have purchased booths um, where they're displaying their products, and they have their sales representatives there to talk to doctors. You can pick up often snacks
Mm.
at their booths. They may be giving out what are called patient aids. So these
Mm.
are tear off um, things that you can give to patients to talk about the disease that they've got.
Mm.
Um, so there's a lot of interaction. In fact, the last figures that I've seen for how much drug companies in Canada are spending on promotion to doctors, this was from 2016. It was $450 million on
Holy.
promotion
Wow.
to Canadian doctors. And drug companies are run by quite smart people, and they're not going to spend $450 million unless they think that they're getting more money back in
Mm.
increased sales.
So on the surface, I think if like when I hear it, and I imagine other people listening to this, the way you kind of walked how that relationship gets formed in all these stages, the lunches, the sales rep meetings, all that. You know, I would think to some extent though, like with sales rep meetings, those are somewhat important because you know it's information that is useful probably for the physician, and these are opportunities to share you know maybe what the latest products are and the latest research or something like that. But what is the line for you that gets crossed that you, or maybe there are multiple lines, but what are those lines I guess that get crossed which make you feel like okay the process or the integrity is lost I guess in the process.
Well, first of all, the general evidence about what happens when doctors and drug companies interact, and I was part of a group that looked at this about 10 years ago. And
Mm,
we evaluated, I think at that point, about 50, 55 studies that have been
mm,
done in different countries around the world. What happens to prescribing? And we looked at three different levels or three different aspects of prescribing. So we looked at the cost of prescribing, we looked at the volume of prescribing, and we looked at how appropriate were the drugs that were being prescribed. And
right.
based on all of these studies, there was one study that showed in that the cost went down. But for all of the other studies, for all of the three different aspects of prescribing, what the literature showed was that either prescribing didn't change or that it got worse. In other words, doctors were prescribing more expensively, they were prescribing drugs more often, and
Mm.
the appropriateness of the prescription went down. And in particular, there was a project that I was involved with that looked at the visits between sales representatives and doctors in Vancouver, Montreal, Sacramento, and Toulouse in France.
Mm.
And so what we did was we got doctors to fill out survey forms after they'd seen these sales reps. And we were
Mm.
particularly interested in how much safety information the sales reps gave to doctors. And
Right.
what we found was that at best, if you talked about things like minor side effects, that was
Mm-hmm.
done in about, I believe, about 1 in 8 visits between sales reps and doctors. And if you went to serious side effects, that was about 1 in 20 visits. And if you went
Wow.
to what are called drug-drug interactions, in other words, if you're taking drug X, watch out if you're going to take drug Y, our drug, because they can produce harmful effects. That was in about 1 in 20
Mm.
um, interactions. So drug reps, at least in our study, and this is across all three countries, all 4 cities, we're not giving out safety information to doctors. So by and large, the message seemed to be that at least when it comes to safety, you should not be listening to the sales representatives.
Mm.
Um, you should be going to unbiased sources of information, and that's not the sales reps.
So that's that research
Oh,
is
there's
very,
another.
very
Let me give you one more,
sure. Yeah.
um, one more anecdote or one more piece of information, which is doctors think that we're not going to be influenced by our interactions with sales reps or with drug companies in general. Um, and this has been looked at in a number of cases. So if you ask me as an individual, am I going to be, or 100 me's, am I going to be influenced by my interactions um, with drug companies? 1 in 100 will say yes, a lot.
Mm.
But if you ask me about my colleagues, are they going to be influenced? Then the answer is about a third of them will be influenced.
Okay.
A
Right.
lot. So we think
Right.
individually that we're invulnerable, but we're not so sure about our colleagues.
That is super fascinating to hear. And so then, how should doctors approach these situations? Like, so has this information been shared with the different medical associations, and like, what's the reaction to this kind of research? I guess.
So, yes, the information has been shared, and things are very slowly getting better.
Mm.
Um, so, as I said a little earlier, about 70% of doctors see sales reps. Um, 30 or 40 years ago, it probably would have been 100% or near
Mm.
100%. Um, and the all of the major medical groups, so the Canadian Medical Association, Canadian College of Family Physicians have
Mm-hmm.
codes around interactions between doctors and drug companies, and they do offer some caution about these kinds of interactions. Um, but by and large, my view and the view that's shared by at least some people is that doctors should not be seeing these sales representatives. That the information, it's not clear that you're getting a full picture about drugs when you see these people. You're getting partial information. You tend to get the information that's most favorable to the companies. And if you want to check whether or not the sales reps not necessarily have lied to you, but have omitted some things, you're going to have to go and read up about the drugs on your own. So if you're going to have to do that, having seen the sales reps, why not just skip the sales reps entirely? And if you want to find out about drugs, um, look up in objective sources and see what they say. And by and large, if you're a GP in Canada,
Mm.
you're only prescribing maybe 100 different drugs. That'll account for virtually everybody that you see in your office. And 100 drugs is not an insurmountable number to be informed about. And then if somebody comes in and you think you need a drug that's not on your usual list, then read up about it. There are, especially now with the internet available, it's pretty easy to get objective information that hasn't been filtered through drug
Mm.
companies. So my advice is skip the skip the sales reps, skip the free lunches. And there was some research done in the United States looking at the effects of meals, sponsored meals of under $20. So
Mm.
about what you would pay if you went into McDonald's.
Mm-hmm.
And that research showed that doctors were influenced by a meal under $20.
Mm.
And, I don't see doctors out on the streets with tin cups saying, we'll treat for food or we'll treat for
Mm.
spare change.
Mm.
Doctors can afford their own meals. We don't have
Mm.
to be going and taking free meals from drug companies.
Totally. So if you're saying skip those lunches, skip the sales rep meetings, what would be the best way for physicians to get that information? Like, I mean, I know you said they could look at some objective research out there. Physicians don't always, I imagine, would say maybe they don't always have the time to do those things. But can there be centralized bodies where those sales reps meet with, and then those centralized bodies can kind of filter down information, or maybe that exists, I don't know, but
Well, we do have, although not well supported, we do have what's called academic detailing.
mm,
So the sales reps from drug companies are known as detailers because they give you the details about the drugs. And
mm,
in places, so in BC, and I believe in a few other provinces, but not widespread, we have our academic detailers. And what
mm,
this involves is you get pharmacists who are trained in person to person interactions, and they
mm,
go out and see doctors and talk
mm,
to doctors about drugs that where the prescribing could be better or where there's over or under prescribing. So you're getting information from professional colleagues who do not have a commercial motivation. And that's one way of delivering objective information to doctors, but as I said, not well supported by provincial governments. In other countries, and I'm thinking here of Australia and the UK, you have objective sources of information, so textbooks that are being underwritten, the cost is being underwritten by government and are available either for free to doctors or at lower costs, where doctors can look up things while patients are in their offices or after patients have left. We've It's been studied that when you doctors get together as groups and they talk about particular diseases, particular drugs, that kind of information improves prescribing. So there are various ways of 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 eliminating the drug companies as sources of information that have been shown to lead to better prescribing. But we need also to get resources into these. So why is it that that governments are leaving a large portion of the cost of underwriting continuing medical education to drug companies? Because when drug companies, that's what they're doing. When drug companies will sponsor lectures at medical conferences, so it might be the Merck lecture in disease X. When drug companies are paying for put money into medical conferences, they don't necessarily choose the speakers, but they're underwriting the cost of these, which makes it easier for doctors to go. But there's also evidence that even when drug companies are not choosing the speakers, that their messaging is still coming through. So I think that governments, and this costs governments money in the end, because to the extent that drug companies' influence leads to poor prescribing, that increases overall healthcare costs. So why is it that governments are willing to tolerate these increases in costs and not try and avoid them by by funding continuing medical education? And I'm not talking here about about governments directly being involved. Doctors won't like that. In fact, I'm not in favor of that. But what I am in favor is governments making money available to unbiased third-party groups, so you can have medical associations getting money from governments and then using that money for continuing medical education as the groups see fit. So the government is just providing the money, but they're not directing how it's going to be used.
Right. That's an interesting idea. You spoke about you're starting to get into talking about the role that pharmacists could play a bit. And I wanted to start shifting towards drug costs, and something we're seeing here in Alberta, and I'm sure in different provinces as well, is the increased role that pharmacists have now in prescribing, for instance, or being able to at least, if the prescription from a physician suggests a certain brand name, that they can then maybe substitute for generics or something like that. What do you think of maybe what looks to be like the increasing role of a pharmacist in the prescribing of drugs, I guess?
So I think pharmacists have a very good training in the use of medications. And I
Mm,
definitely think that we need to be taking more advantage of that. So I don't think that the role of pharmacists is to count out pills,
mm,
or to run necessarily to run small businesses.
mm,
Pharmacists are drug information specialists. And
mm,
I think that's how we should be paying them for those
mm,
roles. And in some places, now this is not necessarily widespread, but some clinics will employ pharmacists, so that doctors write the prescriptions, and then they say, now go down the hall and see so and so, our pharmacist, and they will be able to answer questions for you about these drugs. You can go over the other drugs that you're taking and see whether or not there are any concerns about interactions. If the pharmacists can do audits and see if there might be drugs that you could talk about slowly discontinuing. So I think
mm,
that's an excellent role for pharmacists. Um, Pharmacists are also getting involved in areas like continuing prescriptions that people have been on for a while. So, as I said, I'm old. I'm on some medications for my blood pressure. I've been taking
mm,
these for like 10 years. Um,
mm,
and I don't see any reason why a pharmacist can't renew the prescription um, for me. Um, all they're going to do is right now is call up the doctor and say, "Can Joel Lexchin get a refill on his prescription?" The doctor doesn't have to see
yeah,
me. All the doctor has to do is say yes. Um, but I don't see why the pharmacist has to take that step. Um, Pharmacists are now giving out vaccinations in
yeah.
at least in Ontario. I don't know about
In Alberta too, yeah,
in Alberta.
yeah.
You talked about um, generics, and in
Mm,
fact, this has been something that pharmacists have been doing for decades now, is
mm,
substituting generics for brand name drugs.
mm,
And that's perfectly safe to do. And pharmacists also have a role there because they the generics won't look like the original brand name product. They may be a different shape, they may be a different color, and
mm,
if some people will get confused by that, and pharmacists can explain to people, no, you're getting the same drug. It may look different, but it's going to act just the same. So pharmacists definitely have a major role to play, and I think that uh, we should encourage that role in terms of being drug information specialists, and that's how pharmacists should be making their money, by using their intellectual knowledge, not by necessarily running a small business.
mm. It's really good to hear you talk about that sort of those ideal integration points between, medical clinics, physicians, and pharmacists. And I think more of that is being explored, but it seems like it's being done from a cost cutting perspective, maybe not necessarily from a to the benefit of the patient is what I'm noticing. But I don't know if you're feeling differently. But what more can I guess this would be more the jurisdiction of the provinces, but what can provinces do to further enable or empower pharmacists to take a greater role, I guess?
Um, that's an interesting question. Um, and I think that what what provinces um, need to be able to do is um, is make sure that, like doctors, pharmacists also um, have up to date knowledge about
Mm.
the drugs that they're stocking um,
Mm-hmm.
in their clinic, in their stores, if they're working in stores. So just as physicians need to keep up to date, so do pharmacists. But again, objective sources of information tend to be
Mm-hmm.
limited. Um, there there's safety information, new safety information that's coming out about drugs all the time, but it's not always clear that that's accessible to pharmacists. So we can
Mm.
make that kind of information
For sure. Yeah.
more accessible.
Um,
Um, there's
I guess
also,
maybe
sorry,
just to. Oh no, that's okay. I don't know if there was more if you had more to add there.
there's also software that can help. Um, and this may be already being used, but software that will tell pharmacists um, about drug interactions,
Mm.
so that there can be so that pharmacists can caution patients. Um, I think that provincial governments can encourage interactions between pharmacists and doctors. So sometimes pharmacists are reluctant to call up doctors if they think
Mm-hmm.
that the doctors have prescribed a drug that's not appropriate, um,
Mm.
because doctors will sometimes react badly. They think that the pharmacists don't know what they're talking about. So I think that encouraging this kind of interaction between doctors and physicians. There already is that, but I think encouraging more of that, um, provincial governments can do that.
Mm-hmm. Yeah. Yeah. I want to start shifting a little bit here to drug costs, and then definitely want to end off with our two questions that we ask every guest. But uh, as you know, we're all experiencing these high inflation rates, and I'm sure that drugs are not immune to that, and drug prices are probably rising. You know, there's this conversation right now in at the federal level about universal pharmacare and the role that it needs to play. Where are your thoughts? What are your thoughts on universal pharmacare, and what needs to happen? And also, are you kind of perplexed that sometimes the provinces are not always on board with this sort of thing? I know there's always this tussle between control and jurisdiction and that sort of thing, but it seems to make sense that the federal
Sorry,
government takes
you're
a bit of a lead
freezing
on this. But
on me.
what are your thoughts?
Um, so pharmacare was supposed to actually be part of what we term Medicare. If you go
Mm,
back to the Hall Royal Commission on Healthcare in the mid
mm,
1960s, um,
mm,
we were Hall recommended first provide payment for doctors' services, and then provide payment for drugs. But somehow we skipped that um, second second part of the recommendations, um, and we're still talking about that. So,
mm-hmm,
and what we're finding now is that somewhere in the range of 25% of Canadians um, have difficulty affording the prescriptions that they're getting. So they either
mm-hmm,
don't buy the drugs, or they are splitting pills, or they're skipping doses because of the
mm-hmm,
costs, and that means down the road, higher healthcare costs in general. People are getting sicker because they're not on the medications that they need. And this particularly is affecting what are called the working poor. So if you're on
Mm.
welfare in most provinces, or I think in all provinces actually, you're covered by a provincial drug plan. Um, if you're in a reasonable job, unionized job, or you're in the managerial group, you've got benefits with
Mm.
your job, which covers drug costs. But if you're the working poor, so you're in McDonald's or 7-Eleven,
Mm-hmm.
minimum wage,
Mm-hmm.
you're not getting covered by the provinces. Your job doesn't have benefits. You're paying the full cost of the prescriptions. These are the people who are suffering the most. So we've got
Mm-hmm.
an equity issue in terms of people being able to get medications that they need. There's a cost issue. Um, so there's something, most people have heard of a monopoly situation where there's one seller. The, the reverse is monopsony, which
Mm.
is one buyer.
Mm.
Um, and if you've got a monopsony situation, you can get a much better deal on things.
For
Um,
sure.
but we don't have that in Canada for most drugs. We've got
Mm.
we've got 13 different public drug plans, 10 provinces, 3 territories. Then there are also
Mm-hmm.
5 federal drug plans.
Mm.
Um, and then there are something like 100,000 private plans. So we don't have that kind of unified buying power, which makes
Mm-hmm.
our the cost of our medications higher. So we spend currently in the range of about, I think it's about $30 billion a year on drugs. And
Mm-hmm.
while a universal pharmacare plan would increase public spending, it would decrease overall spending. So the estimates range from savings of $4 to $7 billion overall per year. So we
Mm.
would improve equity, we would decrease costs with universal pharmacare. And the other thing which people often don't consider is that the more what skin in the game that governments have, so skin in this case means money being spent, the more that
Mm.
governments are spending, the more incentive they have to make sure that drugs are being used properly because they don't want to be seen to be wasting public dollars. So
Sure. That's a good point.
governments then start to subsidize um, programs that make sure that patients know um, how to take the drugs appropriately, and how doctors and subsidize education for doctors to prescribe appropriately. So pharmacare is a triple win situation when it
Mm.
comes to using medications. They're used more appropriately. We save on the price of them, and we improve equity. So
Mm.
overall, I think that we should be moving towards a um, a pharmacare program. Now, you talked about the provinces, and the provinces have a reason to be concerned. So back in the 60s, when Medicare started, the
Mm-hmm.
federal government said, we will give you 50% of every dollar that you spend on on health care, on either hospital services or doctor services.
Mm-hmm.
But the
Mm-hmm.
federal government has unilaterally changed the terms of how it's going to give money to the provinces. And the provinces are looking at a pharmacare um, plan and seeing, okay, so right now you're saying you're going to subsidize pharmacare with in this way, but after the next election, are you going to change that?
Mm,
Are you going to be giving us as much money? Are you going to be putting on more conditions? Um,
mm-hmm,
so I think from the federal government's point of view, what they have to do is they have to put in long-term guarantees to the
mm,
provinces about how that money is going to be given to them so that the provinces can safely, because the provinces are also going to be spending money on pharmacare, and the provinces need the assurance that things are not going to be changed unilaterally by the federal government. But these are things that can be worked out. Um, there's going to be bumps in the road, but the
mm-hmm,
federal government and the provinces can do this. I'm quite confident in that. We've seen, for instance, recently there's now childcare um,
mm-hmm,
deals between the federal government and all the provinces. There's going to
mm-hmm,
be a partial dental care program rolled out for
mm-hmm.
families that are making less than $90,000 per year. Um, so these can be done.
Mm. Yeah, no, and I share in your optimism, and you're right. The child care agreement is a good example. I think the federal government though has separate agreements with each province, and it's not
They do.
necessarily across the board, right? So would
No.
it? I guess would they have similar separate agreements in this case for a pharmacare program, or would it have to be across the board?
Well, I would certainly like to see it across the board. I mean, I don't think
Yeah.
that there's a reason if you live in Alberta that things in terms of access to prescription drugs that they should be different than if you live in Ontario. We should be
Mm-hmm.
there should be the same group of drugs that are being publicly subsidized, and if the costs, if there are out of pocket costs, they should be the same. We don't want people having to move from Ontario to Alberta because the drugs that they need are cheaper in Alberta than they are in Ontario.
Mm-hmm. There's so much more I could talk to you about, Joel, and I feel like you and I could have a conversation for a long time. But I am cognizant of your time on a Saturday morning here, and I was maybe we could shift to our final two questions that we ask every guest, if that's okay with you.
Sure.
So the first question for our guests is our five for dinner question: dead or alive, who are five people you would want to have supper with, and curious if you'd want to have them individually or together.
Um, I'd probably want people together. Um,
Okay.
I think that makes for a much livelier conversation, and I think that I'm reasonably smart, but I think that other people can come up with questions or ideas that I would never have thought about.
Mm.
And I enjoy listening to that kind of discussion. So who would I choose? Um, so right now, I think um, that I would go for some of these people are dead, some are alive.
Mm.
I would
Mm.
take Albert Einstein.
Mm-hmm.
Um, I would take somebody who may not be as well known, A.S. Neal. He was
Okay, no, I
the
don't know who that is.
founder of a school in the UK called Summerhill, a so-called
Okay.
free school. He had very radical ideas about education.
Hmm.
Um, I would take Gough Whitlam, who was the prime
Okay.
minister in Australia from 72 to 75, a Labour prime minister who had took did things that really advanced the country
Hmm.
there. It
Was he popular?
changed
Was he a popular prime minister?
um, some of the things he did were popular. Um,
Mm.
Overall, I think that in retrospect, people look back on him as one of the best prime ministers that Australia has ever had.
Mm.
Um, I would take Tommy Douglas
Mm-hmm.
because of his involvement in Medicare.
Mm-hmm.
Um, and the fifth person, um, I would go for Lula, who is, I can't remember his full name, but he's the person from the Workers' Party who's running to be president of Brazil.
Right. Okay. Yeah. Yeah.
And I would
Wasn't there a
like
different?
to say,
There was a different Lula in Brazil as well, wasn't there? Or is it the same Lula
same
that's
one. He
running
was
again?
president
Okay.
before, and now he's running
Yeah.
to be president again. So I would take these people. These people all embody progressive ideas.
Mm.
Um, they come from different fields, um, and they all made a significant mark on their own societies. Um,
Mm.
so I would like to talk to them about what they've done and hear what they think about what's going on right now in the world. I think that we're fortunate to be here in Canada.
Mm-hmm.
Especially when we look around the world, but I think we also there are a lot of challenges in Canada that we need to meet. In some cases, we're doing okay. In some cases, we're doing miserably, and I'd like to hear what they have to say about what's happening in this country and also what's happening in other places around the world.
Mm. Mm. Very incredible five, and yeah, the Lula, and I don't also remember his last name, but I'm hoping he's successful. I think their current
Yes,
president has been a bit challenging to say the least. So
yes, the
um,
Brazilian Donald Trump.
yes, yes, yes. In some cases, maybe arguably worse. So who knows? Um, Final question. Besides the circle of life, what do you know for sure?
What do I know for sure? Um, I know for sure that the best thing that's ever happened to me was getting married to
Mm.
the woman I'm still married to,
Mm.
and having two wonderful kids.
Mm.
That's what I know for sure.
That's amazing. How long have you been married to your wife?
Since
Uh oh.
1984. So what's that? 38 years.
Wow. Wow. Congratulations. That's
I
amazing.
ambushed her in a now closed bookstore in Montreal.
That's so good. That's a great
We
story.
had met at a medical conference and had been chatting, and she said she had gone to medical school in Montreal
Mm.
to McGill, and she said she was
Mm.
going to a bookstore to look around, and there was one quite well-known bookstore, and I was pretty sure that that was where she was going to go. So I walked down, and there she was.
Times have changed. People don't do those sort of things anymore with the internet and stuff. I think
No,
that's quite romantic
you
of you.
order your books over Amazon.
Totally, totally. And then you swipe left or right to find your partner. So it's a very different
Yeah.
ball game nowadays. So, Joel, I really appreciate the conversation. I'm really glad we were able to connect. Just hearing about how you got into the field. To me, I always like to understand the drivers of people. So to know that you went into this because of that sort of social activism, and that even outside of your practice, that you continue to advocate for patients and the right services, and trying to ensure that the system is set up in the best way that patients benefit the most. It's really great to know that people like you exist. So appreciate your time today and appreciate the conversation. I hope you enjoyed yourself as much as I did.
Yep, it's been great. I enjoyed it. Um, and I think listen to what you guys do, you and your colleague Kyle do. And I
Mm,
think you guys, this kind of conversation is great. It's
mm,
feels natural, just sitting around. Be even better if we could do this in person, I think. Um,
you bet.
but but no, I think that you guys are bringing ideas out and exposing them to a larger audience, and some people will agree, and some people will think that this is just a bunch of horse manure. But that's fine; it gets them thinking.
For sure. That's I really appreciate you saying that. I mean, that's kind of been the focus for us, is to have these kind of longer conversations, because people make assumptions and you always hear these sound bites and you don't get the full truth in things. And so we don't edit any of our shows, and we want to hear people fully speak to things. So I'm glad we were able to have this opportunity with you. We'll put all of Joel's information in our show notes so that you can read up on his bio, check out his links to his different books. And again, Joel, thank you so much for joining us today, and we'll see you folks in a couple of weeks with our next episode. Thanks so much.